Bridget, did you want to give a little introduction? Is Bridget still there, Dr. Tagliati?
She's here.
Let's give a little introduction first. So everybody knows a little background about you, okay?
I'm the new movement disorders program administrator here at Cedars, Sinai. I'm trying to get a handle and enhance the program by offering multidisciplinary clinics and support groups. So we just actually happy to announce that we're going to start a support group for newly diagnosed within the last 3 years for Parkinson's, and it starts on June 1st. That's a Monday, 6 to 7:30. So whoever knows someone, or if you're yourself diagnosed within the last 3 years, we would love to have you there. It's a virtual meeting right now, but then eventually it's going to be a group meeting. So, and yeah, if you have any questions, you can always call me. I can email Jennifer my information, and then we can connect. And I'm happy to announce that Dr. Tagliati has this great talk on COVID-19 and Parkinson's, which we're going to hear now.
It's a world premiere. Seriously, it's the first time I presented, and there is a lot of information on Parkinson in particular, and neurological problems related to COVID in general. And I hope you will all find it interesting and informative. And it shouldn't take more than maybe half an hour, so we will have time for question and answers. Any question, any concern. We've been now dealing with this crisis for 6 weeks or more. I see some of my patients there. I want to say hi to them, even if they're muted. And so I'm going to go through this information. Some of that might sound a little technical. Some other might be a little bit more useful. But please feel free to ask questions at the end. Now, let me see if I can share my screen. And Jennifer, you will give me a nod if that is true.
Yeah. So there should be the share screen at the bottom.
We're going to chat.
Okay, I'll let you know when I see it.
That's wrong. It's wrong.
Wait, I saw a share screen.
Go to your PowerPoint.
Yeah, wait, share. Let me see. I need to go into screen.
You go to share screen, the button there?
Yeah, that's what I did. But then it says
desktop.
Yeah, I know. That's what I've done.
Box. Go to box and just put it directly.
Let's see. No, he just doesn't like it. Security and privacy to create access. I think I know what I'm doing. Okay, 1 second. We're trying to security and privacy. Where is security and privacy? Privacy, Zoom. Got it. Will not be able to record. Okay. Wait. Wait done. That's it. I think that we should be good.
Yeah. Okay. Yeah.
Yes, I see your screen now.
Let me get rid of this box. Let me to record. We don't want to record. Okay. Do you guys? Oh, what happened here?
So I'm recording this. Okay. So
can you see? Can you see it now?
I can. Yes.
Perfect. Can you guys see the slides? So let's go.
Yes.
Just give like a thumbs up if you can see everything. Okay.
Thumbs up. Perfect. So let's start from there. Let's see here. Perfect. So most of you know, of course, that the terms Parkinson's disease come from Dr. James Parkinson, that almost exactly 200 years ago described a syndrome characterized by tremors, by stoop posture, by short step gait, over time was identified, was called in his honor Parkinson disease. 100 years later, what is considered probably the most similar pandemic to what we're going through today was the Spanish flu. And the Spanish flu was a key moment for our knowledge of Parkinson's disease, because some of you might know that one of the problems associated with the Spanish flu, which by the way had nothing to do with Spain, you might know, but it was that the brain was affected, and many of these patients would develop an infection of the brain, was called encephalitis lethargica, which basically means sleeping sickness. And the consequences of that encephalitis, of that problem with the brain, was Parkinson's disease, or something very similar to Parkinson's disease. And so a lot of work, a lot of what we know now about Parkinson's disease started with the great number of patients with Spanish flu who ended up having Parkinson's disease. So we learned a tremendous amount. And in fact, what some of you might recognize as the Lewy bodies, right? We all know about the Lewy bodies, which are these small clumps of proteins that are typical in the brain of patients that develop Parkinson's disease, were discovered right at that time by the Russian doctor named Konstantin Tretyakov, who studying people with the Spanish flu and this encephalitis lethargica, discovered that the substantia nigra of these people was affected by the Lewy body. So we learned a lot 100 years ago, and almost exactly 100 years later, here we come. We have the coronavirus disease. 19 simply means that was discovered in 2019. And the numbers keep on changing, but as of a couple of days ago, over 3 million people have been affected. And in the US, we passed 1 million people, 1 million cases, official cases. People estimate there are probably many more than that. And as you all know, it's a big problem because it's a very contagious disease. In other words, it spreads to many more people that, for example, the common flu, about 3 to 4 times as many. So for every person that can get the flu, there are at least 3 or 4 that can get COVID. So it's a very rapidly spreading disease, and which is in part explained, as you might know by now, to the fact that many people don't get any symptom. They don't even get a cough. They don't even get a little flu. And so they go around about their business, especially at the beginning of the pandemic, without being aware of what was going on with them, and therefore spreading it, especially if they take public transportation or if they go to working in a crowded space, spreading to many, many people. And that's why we have witnessed this exponential rise of the cases. You know, there were only a few cases just a month ago, and now we have 1 million just in the United States. And the coronavirus, there are many coronavirus. The common cold virus is a coronavirus. It's nothing new or nothing unknown, but it's a novel one. It's a little bit nastier than the ones before. And it's called coronavirus, as you might already know, because it has a crown of the spikes that the virus uses to literally attach to the cells in our respiratory system and other organs, as we will see, possibly even the brain, and then cause is pathological consequences. And not everything is known. We're literally learning almost day by day what this coronavirus is doing to our body. But there is a specific action that is this binding to this receptor that is called AC2, or angiotensin converting enzyme 2, which is very common in the lungs, and that's why we get the pneumonia, but also in the arteries, in the veins, in the kidneys, and possibly also someone found them also in the substantia nigra, which is where the dopamine cells are produced. And even though I have to say right away, we'll have a lot of slides on Parkinson's disease specifically, but there is no indication that patients with Parkinson are at increased risk or specific risk of getting COVID, or if they do, to have any specific complication different than someone of their same age without Parkinson. So that said, you might be familiar because it's all over the news that symptoms look a little bit like the flu, even though this is not the flu. But it looks like the flu, fever, cough, fatigue that usually occurs somewhere between 2 and 5 days to a maximum of 2 weeks after being exposed. And as I said before, in many people, it stays like that and doesn't go anywhere, but especially in people with older than 60s, it might become more severe. But this is another form of misinformation. This is not a disease that affects only older people. This is a disease that affects virtually every age. And even though it's true that the mortality, as we will see, affects mostly elderly people, people with prior conditions, diabetes, high blood pressure, many young people, as we'll see, can have very, very severe diseases. So the problem of this COVID-19 is that there is a fairly high percentage of people that need to go to the hospital. And because it's so contagious and because so many people tend to be infected, if you have 30, 50% of this infection that needs to go to the hospital, you can imagine that in parts of the world, like New York City or like northern Italy or Madrid, Spain, the hospital might get in great difficulty because they get this surge, literally, of people with pneumonia with similar symptoms that come literally all at once. I have colleagues in New York that in large hospitals with 600-800 beds, which are completely filled with people with pneumonia and COVID. So you can imagine that the tremendous pressure, not to mention, as you have read, I'm sure, the problem with the protective equipment for doctors, for nurses that need to take care of all these patients and literally put it on, put it out, put it on, put it out. There is a tremendous need and a tremendous risk for healthcare providers. We talked about the age, especially over age of 50, and the comorbidities, hypertension, cardiac problem, diabetes, and of course, immunosuppression. People with this condition have to be extra careful because they may have worse consequences of the disease. There is no treatment for COVID-19, like most viral conditions. There are a number, I'm sure you've read the news and the president talking about medications and this and that. The reality is that all these names are ideas, are theories, but there is no proven or recommended medication for COVID-19. So please don't try any of this at home. But of course, the big hope, the big research is dedicated to finding a vaccine, which would, if effective, of course, would put a kibosh on this epidemic. But unfortunately, as of today, we are not close to an effective and proven and safe vaccine. So let's talk a little bit about the brain. That's what we do. And initially, this infection seemed to be mostly like a pulmonary infection, like a respiratory infection, like something like the flu. And there was no much concern about the brain or about neurological complication. And things have changed a little bit. I mean, this is not a neurological disease, but we're starting to pay a little bit more attention because we know that coronaviruses, not necessarily the novel coronavirus, but coronaviruses in general, can infect the brain because we have studied in the past the SARS, the MERS, other type of coronaviruses, and we know that they can enter the nervous system, the brain. It's not clear exactly how. Someone believes maybe through the olfactory nerves, but it's really not well established. But definitely there are a number of experiments. We don't need to go into too much details, especially in animal models. They show that if you inoculate these mice with a coronavirus, you can then find them in the brain. So this virus can go theoretically, again, theoretically can go to the brain. So do we have any evidence that the novel coronavirus cause any neurological problems? Yes. For example, immediately was noted that a lot of patients with COVID-19 have problems with smell and taste. Interestingly enough, similar to what we observe in many patients with Parkinson's disease. And the jury is still out, to be honest, because on one hand, of course, you can have a invasion of the virus in the olfactory nerve that mediates the smell from the nose to the brain. But also, we could have a loss of smell just because of the infection in the respiratory mucosa, and it's not yet clear whether this is a true neurological symptom or just, you know, like a sinusitis or any cold in which, you know, anybody would lose their smell temporarily. The jury is still out, but definitely there is a lot of data, a lot of interest looking at that. But there have been other series, mostly from China, from Wuhan, of course, where this whole pandemic started. And you can see here that they reported many neurological problems, about 30–40%, mostly in the very severe cases, where of course you have an advanced infection and very severe infection. And so of course the brain gets affected just by default. I mean, the brain is part of the body. And so if you have a severe infection and sepsis, the brain will be affected. But again, even though many patients might suffer from neurological problems, they don't seem to be specific of the infection. With, and this is just the numbers, with one possible exception, which is the strokes. A lot of people, about 6% in China and other series showed that a lot of people, too many people, seem to have problems with strokes. And this is pretty scary, I have to say. Even young people, anywhere you can see here from 30 to 50, so very young people, might get strokes. Instead of getting the flu, instead of getting a pneumonia, instead of getting the cough, they get to the hospital with a stroke. Because as I showed you before, the virus could go to the lining of the arteries and cause abnormality of the coagulation and cause strokes. This is has been described in about 5 to 10% of the people, so not too many, not all of them. But when you see people in their 30s coming down with strokes, that's of course is pretty scary. So let's talk a little bit about Parkinson's disease. That's what we are interested in. What do we know about Parkinson's disease? Well, in general, Parkinson's disease doesn't seem to be a pre-existing condition that makes the infection particularly more severe. This is a publication that came out literally 2 days ago, April 29. And you can see the numbers. I mean, this is the northern Italy and England, where there are thousands and thousands of cases, but only 10 were reported with Parkinson's disease. So not too many, to be honest. And all of them were older and with very long or longer disease duration. And unfortunately, 4 out of these 10 ended up dying. And so these authors feel that the older you are and the more advanced is the Parkinson, the more severe is the COVID. But between you and I mean, this is true for anybody. It's not true for Parkinson's disease in particular. Anybody at a mean age of 78, if they get COVID, are at risk of severe consequences. So there is really no evidence in my mind that Parkinson predispose any individual to a more of a chance of catching the disease or more of a chance of having a severe course independent of what we already know, meaning advanced age and pre-existing condition. So again, no evidence showing that Parkinson's disease increases the risk of COVID-19. Experience in Northern Italy does not show an increased risk, but there is no systematic data. This is too early. I mean, we have been dealing with this for only 6 weeks. We don't know whether COVID-19 will have long-term impacts on Parkinson patients, meaning if you survive the disease, whether you'll have more Parkinson, or people that survive COVID might have Parkinson similar to the Spanish flu. It's absolutely not known and is not described. Of course, Parkinson is a disease of aging, and so the increased prevalence of Parkinson with age and the worst symptoms of COVID-19 with age will make a bad sort of connection. But other than that, again, if we follow the precaution and social distancing and what we already know will keep us safe, there is no reason to expect that Parkinson predispose you to having COVID or to have worse COVID. The problem that we have faced so far is what is the consequence that the pandemic, not the virus itself, not the disease itself, but the pandemic, the fact that we have to stay at home, the fact that you cannot go freely to public places like a hospital or like the doctor's office, has or can cause in our population of patients with Parkinson. This is really what we have been working on and what we have been discussing with our colleagues and of course with our patients. So there are two situations, inpatient and outpatient, so in the hospital and in the clinic. And we know that the hospital is not a good place for any patient with Parkinson for whatever reason. Even though, interestingly, patients with Parkinson that have pneumonia tend to survive more, interestingly, of their age and sex-matched patients, but they tend to stay in the hospital a bit longer. But there is, as I said, no data specifically related to advanced respiratory disease syndrome or COVID in particular. And of course, nobody with Parkinson's should be in the hospital for no good reason, because there are a number of high risk complications like delirium, drug reaction, pneumonia, falling when you get out of bed. So in general, unless there is a good reason, but that's, again, true for everybody, we should stay away from the hospital in this time of pandemic. At the same time, I've read some reports of people that don't go to the hospital even with signs of heart attack or stroke because they're afraid of COVID, and that is the opposite problem. If there is a serious symptom, we should always call our doctor, and if you need to go to the hospital, you should go to the hospital, especially here in Los Angeles. The good news is that the hospitals are not overwhelmed with cases of COVID-19. We have our share, but we are not overwhelmed. You're not even close to what New York, unfortunately, or Detroit or New Orleans have. And so we can safely come to the hospital and be admitted in a floor that is far and away from COVID. Every patient is tested ahead of time when they come through the hospital. Of course, there is a risk of being in the emergency room. You don't know who is around you. But in general, if there are proper reasons to be admitted, that shouldn't be unnecessarily delayed, okay? So what is the impact of the pandemic? Forget about the infection. Hopefully none of us will get infected, but the stress, the general stress that this situation, that this crisis, that the lockdown, that the news bring on to us, it's unavoidable. It's unavoidable. We are all under unusual type of stress, and we all know that stress makes Parkinson worse. There is no way around. Tremor is worse. For those who have problems with freezing, they might have more freezing. The dyskinesia might get worse. And even if we don't know whether stress, chronic stress, can accelerate the progression of Parkinson's disease, I've heard several of my patients telling me that they feel that their disease seems to have to get a little bit worse, and for no other good reasons that this chronic daily preoccupation of where we're going to be, you know, in 2 weeks or in 2 months. Also, some patients with Parkinson are described to be a little bit more inflexible and rigid, so it might be more difficult for some of them to cope with this situation, and the depression might become a problem, the anxiety might become a problem. And last but not least, and Jennifer, I'm sure, will testimony to that, the closing of the gyms and the closing of many programs has caused a marked reduction in the ability to have physical activity, or at least sometimes of physical activities, and that we know might result over the medium to long term into worse motor progression that we would have having physical activity. And maybe we will discuss that a little bit more in detail. So the silver lining has been that we have had the opportunity to use more telemedicine. Telemedicine for Parkinson's disease has been shown now for years to be a potentially a very, very helpful tool, but the regulatory agency and the insurance have been always been very, very conservative, very, very stingy, so to speak, in approving telemedicine. But since COVID came around, the door opened up almost magically, because of course the need for telemedicine became immediate, and so now restriction has been lifted and we are able to use telemedicine quite a bit. And this is particularly helpful for patients with Parkinson's disease who need routine visits to the hospital, that need routine physical assessment and medication adjustments by neurologists or movement disorder specialists. And of course, we, unless necessary for whatever reason, we don't want patients with Parkinson, especially if they're elderly, to get around the city and come to hospitals and potentially being exposed to contagion. So the remote neurological care, the video conferencing, and also the remote monitoring, in some cases with sensors to see the tremors and the freezing of gait, can be very, very helpful. Actually, it is very helpful. We have been doing it daily. We can visualize the physical examination. We can do an abbreviated form of our Parkinson neurological exam, because we can see almost everything through the video, with the possible exception of rigidity, which we need to test manually. Everything else can be tested. It's not as good as in person, but it's good enough to make immediate decisions, especially for people that need to drive long distances, or in this case don't feel safe to come to the hospital. And in fact, the telemedicine has been studied in Parkinson's disease. There are the 4 C's: access to care, convenience, comfort, confidentiality, and now there's the 5th C, which is contagion, COVID-19, because we want to keep people at home as much as possible. And so we have started to get a lot of experience on telemedicine, and we really hope that when this whole crisis will pass, because it will pass, there's no question about that, we will have one more tool under our belt to work better with our population of patients with Parkinson. And these are some resources, mostly for doctors that want to set up telemedicine, but you're welcome to. I can share the slides, Jennifer, for your group. This is more for clinic, for doctors that want to set up a telemedicine service. Is there anybody who has DBS in this group? Because yeah, good. So the DBS is pose another specific problem, right? Because patients with deep brain stimulation need a number of resources and assistance. They go from the surgery to, of course, the programming and the follow-up. And so this is just a classification of how we, as doctor, look at the emergency, right, of procedures. So anything that can be postponed for at least a month is elective and has been suspended, at least for the last month. I think that we are reopening a little bit to elective procedures. Then there is time-sensitive, urgent, within 24 hours, an emergency right away. And similar to outpatient clinic, to follow-up clinic, elective can be deferred. You can do it over the phone. You can do it with a video call. Or urgent, you need to come because it might be dangerous not to address the problem. So with that definition in mind, for example, implanting a DBS lead is considered an elective procedure. It's never an emergency. It's never a matter of life or death. And in fact, in many hospitals, including Cedars Sinai, it has been suspended. Although the good news is that we have reopened to deep brain stimulation implantation last week, very carefully, very, how can I say, with great grain of salt and specific deliberation. But we are able, for those who need it or have been waiting to have a deep brain stimulation implant, we're able now to implant the leads. And during the successive phase, the phase of programming, we need normally visits for assessment and adjustments. And there are a number of reasons why we may need to see people. Of course, if everything is good and is unchanged, we can do these things over the phone. But the reality is that we need always to check the device, if anything else, to make sure that the battery life is not going toward the end of life. And so we need to change the battery. We need to make sure that there are no infections going. It's not that common, but it's possible. Whether there are no breaks or what we call hardware-related complication. And of course, many patients need adjustments because we have not optimized their stimulation yet. And there are a number of steps. We don't need to go to that in detail, but it's an interesting algorithm that was offered by some doctors in the literature that basically help physicians and patients alike to decide whether they need to take a little bit of a chance and come to the hospital, or they can wait and manage without taking a chance to come to the hospital or to the doctor's office. And so these are, again, these are more for doctors. It's a little bit more technical, but these are what we consider situations that might be life-threatening and therefore cause emergency visit to the hospital or other in which we don't think that we need to rush anybody and take any chance. So the outpatient programming is, of course, a very important steps in deep brain stimulation. As you know, the implant by itself doesn't do anything. You need to have regular programming. And there are several recommendations. The initial programming can be postponed if it's necessary, as well as routine simulation adjustments. Some people can be seen over the phone or over the video if they have pre-programmed settings that they can move up and down by themselves, maybe with some supervision of a nurse or a doctor. But if people with patients with Parkinson's disease and deep brain stimulation have changes in their symptoms, a tremor that was well controlled all of a sudden starts breaking through, those are situations in which we invite them to come to the hospital. We have been here, I didn't miss one day in the hospital so far, because there is always at least one or two patients every day that might need an immediate help because of their deep brain stimulation device. A last few slides on research and clinical trials. I don't know if anybody of you is part of clinical trials. Of course, in a disease like Parkinson's disease that doesn't have a cure and it still has a tremendous research activity and opportunity, This has been a very, very delicate issue because a lot of the research has been affected by the pandemic. Many laboratories and many studies have been closed or have reduced their activities, especially new recruitment, like new patients that we stopped the recruitment of new patients in the clinical trials. But we had a lot of people that were already taking a experimental medication. And so in that case, we have maintained the options to see them regularly as needed. Of course, if they didn't want to come, we wouldn't force them, but we were there for them if they had a problem, first of all, but also if there was a pre-set follow-up visit. In general, the good news about research is that we have been able to continue basic activity, and as of yesterday, our dean has cautiously reopened new enrollment, making sure that we avoid a situation in which too many people might be in the same room or too many patients might be in the waiting room. But we have been able to cautiously reopen enrollment, and we are gonna take cautious steps to invite people that are interested, of course, to come and participate to clinical trials. Of course, all measure of social distances, we highly recommend to stay according to the authorities and according, I would say, also to good common sense sometimes. We, however, do not recommend to postpone important a trip to the hospital for serious symptoms like a heart attack or a stroke. And we will postpone, we have postponed, not anymore, deep brain stimulation surgeries, same for outpatient visits. But, and these are some of the examples that we provide that might require direct contact and therefore a visit to the hospital, are checking deep brain stimulation programming, pump, levodopa pump, or botulinum toxin injections that might cause severe symptoms if not repeated at a certain time. So COVID-19 rapidly changing how we live and practice medicine. The nervous system manifestations are common in severe infection and might be secondary, although it's not yet well established, to direct action of the virus on the brain. It's too early to know whether COVID-19 will have long-term neurological complications like the Spanish flu, but it's definitely transforming the way we practice the neurological care, particularly for patients, for people with Parkinson's disease. And even though there is no evidence, again, there is no evidence that Parkinson's disease increases the risk of infection with the novel coronavirus. Most patients with Parkinson's disease are older than 60, and so they have an increased vulnerability, higher risk of in-hospital complication, increased level of stress, deficient coping mechanism, and reduced treatment, which are unfortunately destined to somehow make the disease at least temporarily worse. Good news come from the increased use of medicine and remote monitoring that we will learn to use more, and hopefully insurances and authorities will liberalize a little bit because they can be extremely helpful in good hands. And we reduce some deep brain stimulation and research related issues. So I hope I gave you a good, I want to thank all my colleagues and friends here at Cedars, but interesting, we were with a group of Chinese doctors, which seems to be relevant for what we just discussed. But the situation is still ongoing, but we feel very, very confident that we can provide continuous care and support to our patients. The good news, and I don't know if you have any different experience, but the good news that none of my patients that I know of has been positive for the coronavirus. In other words, I have zero infection rate in my patients with Parkinson's disease that I know of. I mean, some of them might not have let me know. And so it looks like either I have very smart patients that stay at home, or we have not, as I said, encounter a increased predisposition, increased vulnerability to the infection in patients with Parkinson's disease. Thank you all for your attention. We have I have time for questions. I'm sure that there are a few. Jennifer, I'll give you back the microphone so you can moderate this.
Okay.
Thank you, Dr. Tagliati.
So just stop your share screen.
Let me try.
And then we'll go back to, let's see.
Stop share. There you go.
There we go. There we go. Okay.
Thank you very much.
So, thank you so much, Dr. Tagliati. Really, really appreciate you coming in and giving that presentation. I am going to go ahead and start going over some of the questions that people have already submitted. Let me go back here. Let's see. So the first question I have is from 2 or 3 different people. It's the same similar question. Basically asking, does Parkinson's deplete your immune system? Does it affect either people with Parkinson's, or we have a couple of people in here that have Fragile X syndrome. So does having that automatically affect the immune system and therefore make us higher risk for COVID?
Question, very good question, and I have specifically researched that, and early in the pandemic, and I should have put a slides. Actually, I'm gonna put some specific information about that, but there is no evidence that Parkinson's disease affects the immune system. So the fact of having a diagnosis of Parkinson's disease does not, either directly or indirectly, none of the medication that we use are immunosuppressant. And so there is no reason to believe that having Parkinson increase the vulnerability to COVID-19 because of immune suppression. The same can be said to some degree also for respiratory function. Even though a very advanced Parkinson might predispose to aspiration pneumonia, to some problem with respiration, there is no evidence that the Parkinson's disease can be comparable, for example, to chronic obstructive pulmonary disease, which is or asthma, which are well-known risk factor for severe COVID. So neither the immune system nor the respiratory system are specifically affected by Parkinson. And that's why, again, I want to say Parkinson's disease, in my mind, and so far in the literature, is not considered, other than the fact that it affects people with older ages, a specific risk factor for infection and for worse sort of complications of the infection.
Right, and I've been talking to a lot of different groups and know a lot of people with Parkinson's all over. And I have not heard of one single person yet with Parkinson's with COVID. So hopefully we're just doing the right things. We're staying at home, protecting ourselves, and hopefully, again, not being at risk. Let's see. So I have a question. It just came up. Let's see. Okay. So the next question would be, if there's one single most important thing you would tell a person with Parkinson's to do, what would that be?
In COVID?
I'm not sure if it's COVID or if it's in the general, what you should do to help, if you have Parkinson's, what's the most important thing that you could be doing?
So there are many things. I can pick one, but excluding COVID from the picture, the most important thing is to exercise, of course, and to be compliant with their medication, unless there are side effects or other problems. Within the context of COVID, unfortunately, at the current state of the situation, and we are in what we call a mitigation phase. unfortunately, the best thing to do is to stay home and minimize the contact with the potential sources of infection, which again does not mean necessarily that you have to stay, you know, with your windows closed and never put your nose outside of the house. It depends on the environment and on the situation. But you know, if it's safe, if you live in an area where there are not too many people, having a nice walk around the house, again, it depends on the environment and on the crowding of the streets around your place. But we need to somehow compensate for the lack of exercise. It's very, very important for a patient with Parkinson's to maintain mobility. So having maybe a cycling, you know, something, a stationary bike, or an opportunity to take a regular walk with a mask and staying away from unnecessary contacts. It's again, it's difficult to generalize because I don't know what the situation is for everybody. I can tell you personally, I'm young, but I'm not that young anymore. So I come here to the hospital every day, but I keep my exercise. I never exercised so much in my life, and I've exercised quite a bit. So you need exercise, and it boosts your immune system, by the way, in addition of reducing the progression of Parkinson's disease. So try to find safe ways to maintain your mobility.
Right, and that's one of the things that we do here, not just having presentations like yours, but we have classes 5 days a week. You can come in, do a boxing class, do a circuit class, as well as nutrition, mindfulness. So we have we have the technology to be able to keep people connected and keep people staying active during this time. So it's really important.
I have heard across the world, I've heard a great use of online classes. I have, as you know, I'm from Italy, where the pandemic has taken a big toll. And so I have several colleagues and physical therapists and exercise experts that have organized successfully online classes. So that's another way to maintain the mobility. And so, yes, that's something that I highly recommend. I see a question here on the chat. Can I take that, Jennifer? Is that okay?
Yes. Go ahead.
So he says, thank you, and you're very welcome for the presentation. And it's a very clever, very good question. So with the seemingly increased progression of Parkinson during this pandemic, do you feel it could be also possible to reverse them when things get back to normal life? My instinctive answer is yes. As I mentioned during my presentation, it's not clear, it's not established that stress will increase the progression of the disease. Definitely, it can cause breakthrough of certain symptoms, particularly tremor, particularly freezing of gait for those who experience them, because they're well known to be associated with anxiety and with stress, or dyskinesia sometimes. But we also know that when the stress, when the adrenaline, so to speak, subsides and reduces again, those symptoms tend to go away. It really depends how long this situation will last. If it's going to be relatively contained in terms of weeks or maybe a few months, I don't expect Parkinson to be worse. Of course, if we stay home for 2 years, or if this goes beyond expectation, that might take a toll on anybody, not just on patients with Parkinson's disease, but unfortunately, particularly on patients with Parkinson's disease. So I'm an optimist at heart, and I hope that something positive will happen. But yes, the current stress can make some of you feel worse, and don't necessarily take it as a symptom progression of the disease. But it is not easy for anybody to be in this situation. This is the biggest healthcare crisis in generations, in a century, and we're all improvising to some degree. Yes, I see a further comment. So we can talk in general about cognitive functions. In general, also cognitive function can take a toll when you're under stress. Stress mechanisms and noradrenaline tend to suppress our cognitive because we are in a fight, right, situation, and so we don't need to think too much. We need to run, and so that might take a toll. Cognitive function is also very, very associated with sleep. So if sleep is affected by the preoccupation, by the news, turn off that TV in as much as you can, even though we're all somewhat addicted, whether pro-Trump or against Trump. I'm not going to get into that, but the news can be very addictive and can be very worrisome, and they can affect our sleep. Sleep is very important for cognition. So if sleep is a problem, which unfortunately normally is with Parkinson, make sure you have a conversation with your doctor to maybe take some temporary remedies to improve sleep. It is definitely a possible consequence of the lockdown, the lack of physical activity, and the stress of the situation. It's definitely a possibility. Again, eat well, sleep well, and exercise remain the basic golden rules to keep this disease from progressing. I have another question about donating blood or plasma. Any medical reason to donate or avoid donating? So, great question. Thank you for Andy. Thank you to Andy for asking this. So, the donation of plasma can have a tremendous value if you had COVID-19 and you survived, because anybody who is faced with an infection will develop antibodies. And antibodies can be transferred to a patient that is fighting with the disease, maybe is not able to produce enough antibodies of his own or her own. And so there is current research that seems to indicate that transferring plasma rich with antibody against coronavirus can help people survive the infection. However, if you didn't have coronavirus, then donating plasma is probably not as helpful. Now, donating blood is always helpful. If you're a donor, kudos to you. There is tremendous help, a tremendous need for blood in the hospitals, especially in a time of crisis like this. But the specific point of donating plasma is valid for people who had the infection and may donate their antibodies for therapy or for research. Any more questions, Jennifer?
I do have some questions that were submitted earlier. This one, I have two people that asked a similar question. So, should one be weaned off medications and only take for a specific length of time, like such as Sinemet? The other one is very similar. They said that they experienced certain side effects from the Sinemet. They plan to stop the Sinemet and start again after a while to see if that particular side effect stops. I'm aware that rigidity and tremor and other symptoms will appear during the pause. My question is if any long-term deficits or damage or worse symptoms will prevail as a result of pausing the Sinemet.
So I'm not sure why we would pause the Sinemet. I usually, unless there is a specific side effects like hallucinations or severe nausea or severe dyskinesias, stopping the Sinemet or the levodopa and whatever formulation is taken is usually not a good idea and can predispose people to have severe exacerbation of the symptoms. In particular, during a period like this, if anything, the question would be, should we take a little bit more if our symptoms are getting worse due to the chronic stress or other reasons? And in general, I'm very conservative in increasing medication for temporary period, but it depends on case by case. It's difficult to give a generalizing answer. I would not recommend, unless specific cases and exception, to suspend or cut down the levodopa in any moment.
Yes, especially if you've been on it for quite some time, and you can have severe symptoms. And because I've been in the case where the medication stopped working for 2 months, and it was a terrible thing. So be very, very careful and talk to your doctor with those specific situations. And so that way you can decide on what the best route for you is.
I see an interesting question from Robert and Patty. Very, very interesting question. Could there be a natural barrier to virus from taking Sinemet? That is something that is currently under scrutiny, under study. I know in Italy, there is some speculation that might be the case. But I have not found yet any confirmation one way or another that taking levodopa might confer extra protection against the virus. But this is a very interesting question, because there are researchers that are studying that specific point. And part of the reason why they're studying that point is that there seems to be, as we've seen, a very low a percentage of patients with Parkinson that seems to be infected with coronavirus. And again, that on one hand could be the effect of the prudence of the fact that being ahead with the age keep you naturally more at home and more concerned about getting this infection. But there could be a specific protective role of the levodopa, and this is under study. So I cannot answer directly your question, but it's a great question, and someone is studying that. Maybe we'll know something soon.
Okay, so I think we have maybe time for a couple more quick questions, and I think we're going to wrap it up from there. One would be, are you aware of any research in the use of CBD oil or NADH to treat Parkinson's?
Yes. There is a lot of interest in this. NADH has been studied for so long that I have to be honest. I mean, if something was true, it would have come out by now. CBD oil is a little bit more of a recent phenomenon due to the legalization of marijuana, of products in many states. And in general, I don't have a specific opinion about NADH. It's an antioxidant, so in theory it would be helpful, but I never found conclusive results. For CBD oil, there is a clear relaxing, right, effect, almost a little bit like a Valium type effect, but without, of course, taking the Valium, which, of course, can be very, very helpful in some cases in which anxiety, stress, increased nervousness might be at the root of some of the Parkinson's cases, like tremor, like dyskinesias, etc. In fact, the famous video that everybody knows of this gentleman with severe dyskinesia then takes, I don't remember if it was CBD oil or something like that, and the dyskinesia go away. It's relatively simple to explain with the tranquilizing Valium type effect of CBD oil. Many of my patients take CBD oil before going to bed. It's one of those things. It's similar to vitamins. That there is a lot of anecdotal experience, meaning a lot of good or individual responses, but there are not many studies yet. There are a number with what we call small series, meaning only a few patients, usually self-selected. But this will come out because now that the compound is legal and there is an increased interest in these products, there is less stigma in using them, and so the information will come out soon.
And then I think some Raven just said, what about MitoQ supplement?
Say again, what kind of
It
supplements?
says MitoQ. I'm not sure. Is that? I know about CoQ10, but not. I don't know about MitoQ.
I'm not sure about MinoQ. Let me see. Let me see if I'll, unless it's something, MINOQ.
It says MITO, like mitochondria, might be. It's MITOQ.
So mitochondria, of course, are very important part of the cell. So here, oh, it's a coenzyme Q10. Yes.
Oh,
So
okay.
coenzyme is a supercharged, as is described as a supercharged coenzyme Q10. So coenzyme Q10 has a long history with Parkinson's disease. 20 years ago, there was a study that seemed to show that supplementing coenzyme Q10 would tremendously reduce the progression of the disease. I have to say that there was a large study sponsored by the NIH that did not confirm that initial impression. That coenzyme Q10 was administered in that original study with a lot of vitamin E, which we know it can be very, very helpful for Parkinson's disease. In fact, I always recommend vitamin E-rich diet for patients with Parkinson's disease. So I cannot really recommend coenzyme Q10 specifically. Now, I don't need this going to hurt anybody, but if it costs a lot of money, I would prefer a good avocado or a good salad is probably going to give you more antioxidants than those pills.
Okay. And then the last question from Dottie, let's go ahead and take hers. What can you do for excess tremors?
Great question. So tremors are, I like to say sometimes they take a life of its own. So tremor is tremendously dependent on our level of anxiety. So if we are nervous for whatever reason, if we don't sleep well, if we are under lockdown, the tremor might come a little bit more. And that has been seen is not necessarily a effect of the progression of the disease. It's just an effect of being activated, of being nervous, of being stressed, of being anxious. What can you do in those cases? So we can do several things. It depends. We would have to have conversations one-on-one. Of course, you can take a little bit more levodopa. There are medications specific for tremor that are called anticholinergics. We tend to be a little bit conservative in using anticholinergics because they can cause memory and cognitive decline. And so not everybody can tolerate those medications. You can work on your lifestyle and your sleep and reduce the chance of feeling sort of stressed or irritated or low in energy and energy to cope with situations. So from lifestyle to specific medication, there are many remedies that probably should be discussed on an individual basis with your doctor.
Okay. All right. Well, thank you so much,
Yes,
Dr. Tagliati, and thank you all of you guys for the great questions.
Jennifer, just 1 second. I see someone asking vitamin
sure.
E
One
diet
last thing?
examples. So leafy vegetables, vegetable oils. If you like avocado, it's a great source of vitamin E, and nuts. Unless you have specific allergies, nuts are rich in vitamin E. Splurge on nuts is gonna be extremely helpful over the long term. Remember, these are not anti-Parkinson medications or anti-Parkinson compound, but from now to the next 10 years, it may reduce the progression of the disease.
All right. Thank you so much.
Thank you. Thank you from the Ventura Parkinson's Disease Support Group very much, Doctor. Maybe we can have you someday in person.
Absolutely. Absolutely.
You look like you have our ocean behind you.
It's just a photo. But
It looks like Ventura.
I'm not at the beach.
Thanks a lot.
Come up here and come to the beach. You can walk on our beaches. It's legal
You guys are open. I know. I'll come there.
every day.
I unmute everybody. So thank you so much again. Thank you guys all for coming. Thank you, Dr. Tagliati. We really appreciate this.
Thank you.
Bye.
Thanks, doctor.